Bu atraktif bölümü Sayın Khalid El Sabti'den dinliyoruz. Yes.
Thank you very much. Good afternoon. Good afternoon, everyone. First, I would like to thank the organizers and Dr. Murad for their kind invitation for me to come over here and give my talk. We are switching gears to surgical stuff after having a diagnostic. OCT has been well explained. I'm going to talk about the new technology of 3D visualization, the heads-up 3D technology or digitally assisted 3D technology recently released. It is not really recent, has been there for a few years, but recently it became very popular as many surgeons are using this 3D technology or 3D assisted technology. I'm going to talk about the main features and basics of this technology and followed by 3D videos, and I would like to ask each and everyone should have 3D glasses for the second part of my talk, which is showing some of my interesting cases. The evolution of 3D technology has started a few years ago, and it has been evolved since the beginning, where has been some advancement and some of the features of this technology to become an even better. However, it is still an evolving technology, and we are expecting to see more and more advancement as we go through this technology. So phase 1, when it was launched, followed by phase 2, and then the phase 3, which is basically the integration of the Ingenuity or 3D technology with other like surgical vitrectomy machine, the Constellation. What is the system today? How it works and what is composed of? It's a digital camera, 3D digital camera that's connected to a video processor and a high definition 4K screen. The camera is very specific. It gives a very high resolution of imaging, which is being transmitted to the video processor, to the screen through a video processor that processes the images into 3D formation. The video processor is very fast and it records all your cases. You have to, obviously, everybody in the operating room, surgeons and others, has to wear glasses, passive glasses, to be able to see the surgery. And the advantage here is that everybody is able to see exactly what the surgeon is seeing, and this is a big advantage, a teaching advantage for modern vitreoretinal surgery. So the main thing here is to be able to do surgery, and others can see you, as I mentioned, and also it can offer some benefits of patients who cannot lie flat. I'm gonna go through this and show some example where patients cannot lie flat will be able to do the surgery. I will highlight some of the features of this technology is the enhancement of depth perception and focus. And as you can see here, the depth perception or focus is a big concern about vitreoretinal surgery, where we want to be always in focus to be able to perform an excellent surgery. What affects the depth of field? Depth of field is a very important thing during surgery. Is many factors that affecting it. Basically is the magnification. As you go higher in magnification, the depth of field become less, and vice versa. And also the aperture of the camera, which you can control as a surgeon, increasing and decreasing it can affect also your depth of field. Enhancement of depth of field is quite critical, especially when we do microsurgery, as we all know. And I will show you some of the examples. I'm going to show you how this enhancement of depth of field is very important. It's not now. The video will show after. So I'm gonna go through it. The videos, I put the videos after the presentation. So magnification is another feature of this digital enhanced visualization system, where you can see in a very great detail. The peripheral acuity is extremely important, that you can see also maintain your focus or acuity even when you're looking at peripheral field. Another advantage of this technology, as I will show you some of the examples, is the filters. You can pre-program or use already existing filters in the system to enhance some areas or surgical structure during surgery, for example, vitreous, or even if you want to see the blood vessels, as I will show you some of the examples in a few minutes. One of the important things is the posture-related back or neck pain among surgeons. Certainly, ophthalmologists and retina surgeons are prone to this complications on a long-term complications of sitting on a microscope. And theoretically, and has been shown that improving the posture of the surgeon may minimize the complications of back-related problems. As you can see here in this technology, we don't need to lean forward to do the surgery. You can relax, and you can sit the way you want in a very relaxed position, so you can perform the surgery with no stress on your neck. The 3D technology is important, as the surgeon is not attached to the microscope anymore. Theoretically, the patient can be in any position, and I have seen or come across patients that will be unable to lie flat on their back because of multiple medical problems, and we had to do the surgery on a semi-sitting position, and I used to do them standing before. And now with this technology, you can keep the patient on 45 degrees, and you can operate without being close to the microscope. So this gives you some freedom from the microscope and to get the optimum position for your patients and for you as well, so you can maintain and do the long procedure for some critically ill patients that cannot lie flat. What is coming up in the future? So this technology, as I said, is an evolving technology. There will be a lot of advancement, and there will be some more indications, and perhaps more people, as people use it more, they will probably discover some of these advantages with time. For example, the newly released software of this system will allow you to integrate the Ingenuity with the Constellation to be able to control with foot switch of two systems together, and you don't need the assistant to help you to do the image inversion and recording, etc. And you can also set preset parameters that will also integrate the Constellation cutting rates and vacuum. Also, you'll be able to see all the parameters in the screen of the Ingenuity, the cut rate, etc. The foot switch is upgrade with the technology is in the new release, and I think anybody who's buying this technology might get it in the near future. What other advantages of this technology is its ability to be integrated with other modalities. For example, as I can see here, I'm one of the endoscopy users. So before Ingenuity, I used to put the screen of the endoscope on the side, and I have to look between the microscope and the endoscope back and forth, which is really kind of distressing to me. But now you can integrate with the Ingenuity the endoscope, you can integrate OCT, you can integrate live OCT, like rescan, for example, that you can put it in the split screen and will be very, very helpful to look back and forth between the two technologies. This is, for example, one of the cases that I integrated the endoscope with the Ingenuity in a non-dilating pupil with a detachment. I wanted to see how this two systems working together help us to look through things. For example, this is a detachment where you can see on the left side is the Ingenuity. It's not a 3D. You will see it afterwards. And this is the endoscope. Basically, this is the break that you see, peripheral break with both. I'm using the endoscope endolight as the endo illumination, so I don't need to put a chandelier here. So this is the detachment. As we flatten the retina, the break is getting away from the field of view in the Ingenuity. That's why I will be relying in the peripheral view with the endoscope. So this is something you get to know with time. You get to get more experience, and you get very comfortable. As you can see, the brake is here, and this is the Ingenuity side, and this is the endoscope side. I don't see it distracting, as many has suggested. It is really complementing each other. You get draining subretinal fluid, as you can see here with two systems. The advantage of the endoscopy, you can get very close, and you can see the brake very closely. So you can see here, I'm draining subretinal fluid during reattaching the retina's detachment in this particular case. So this is really something you can integrate. So what other things that can come in the near future? That's my suggestion, is robotic eye surgery. People are talking about robotic eye surgery. Now, this is Mark D. Smith playing with his robot. This is not what I want. The robot is the remote surgery, where the surgeon is in Istanbul, for example, and the patient is somewhere else in Budrom or somewhere else where they need to have robotic surgery. So if you can see theoretically as good as the surgeon remotely, and if you can transmit your skills to the other side theoretically, this is the major part of robotic eye surgery. The other thing is adding some of the indicators for safety, for example, phototoxicity indicator, to the system that measures the amount of light and induced inside the eye. And when you reach the level of phototoxicity, it will give you an alarm that you have been in the eye for long enough that you may cause phototoxicity. So these are indicators that can be very important. Now we will switch to the 3D videos, and if I go down, and everybody can put the glasses. Can we have the videos, please? This is a branch retinal artery case. And as you can see here, the occlusion is at the bifurcation and causing the artery occlusion, retinal occlusion. As you can see, the embolus is quite here. This is done by the Ingenuity. As you can see here, I'm trying to unblock the artery by doing a gentle massage to the branch retinal artery, as you can see here, and you can see some of the emboli has been already successfully moved through the artery with a gentle massage, as you can see here. So a gentle massage through with a back flush needle, I was successful to be able to remove most. I have counted almost 20 emboli coming from this. So it's very strange that how much from small artery, how much emboli can be mobilized. You have to be very gentle, as you can see here, gentle massage, and be patient to be able to open up the artery and remove the embolus to a peripheral location rather than closer location. So this is my second case I have done in my practice, and it worked very well. The only problem is the timing of the surgery was a bit delayed, few hours, but the retina was reperfused and the patient started. This is switching the filters to see the difference. And why I'm using green filter here? Because I wanted to see the artery better. So for better visualization, we do the filters. The artery has opened. This is a week after surgery. As you can see, the embolus is here, and the main artery, which is blocked, has been opened successfully. Another case, which I don't suggest that most of the beginners with Ingenuity should do, it's a very brave procedure. This is a hemivein occlusion because of the artery impinging and causing the occlusion at the edge of the disc, as you can see here. So this is a vein occlusion by this artery. So the vein occlusion is somewhere here. So I wanted to do schizotomy, or try to do schizotomy, although it is a very controversial subject, but it has been working with some of cases. So first, putting perfluorocarbon liquid to protect the area, make sure also to push if any blood comes. I did cataract surgery with the Ingenuity, and I did posterior capsulotomy. What I wanted here to use, which I feel is the safest, is using the 10-0 nylon spatulated needle to be able, it has a better control. So I put it through the anterior capsule, posterior capsule, and then with the forceps, and putting the thread in the sideboard of phaco, because if I drop the needle, it will not go to the retina. Now, trying to go between the artery and the vein, as easy it looks, it's not very easy. Believe me, it's very stressful. So now switching the filters, just to show you the differences between the filters. As you can see, I'm below the artery here. The needle is safely removed. And then with the spatula, I was able to spread the sheathotomy and increase the space, allowing the reperfusion of the vein. And then finally, the lens was put back. So this is the second case. Third case is, this is my third case I have done in my life. This is a detachment due to retinoschisis. I don't know how much you see retinoschisis. Clearly, you can see the outer retinal holes, and then now you will see the inner retinal holes. So I have to reattach. As you can see here, I'm doing the hyaloid separation, posterior hyaloid separation here. This is the area has to come back because there's strong adhesions here. Now turning it to green filter will show me the posterior hyaloid even better, and removing the hyaloid gently. And the breaks are quite here. So 3 or 4 breaks that cause the inner breaks cause the detachment, not the outer breaks. As you can see here, removing the hyaloid, the breaks are 1, 2, 3, 2, 3 here, and I started to drain from the inner breaks, and you can see the outer breaks as well. So the detachment from the inner breaks. So removing most of the fluid. Now the challenge is when you do laser, you cannot do laser when the outer breaks is the outer retina, because it's not going to be sticking to the choroid and the inner retina. So I had to remove the outer retinal layer just around the breaks to allow chorioretinal adhesions after laser photocoagulation. Not the whole outer retina, obviously, you don't need to do that. So now, with the help with my light, I'm trying to trim all the outer retina from around the breaks to allow it. This is doing dry vitrectomy, and this is a very suspicious area that I wanted to remove the vitreous condensation and the retina as well, retinectomy. The air fluid exchange, look at the outer holes here, started to be shown, and then finally silicone oil injection. Patient did very well. 2 months post-op, you cannot see the outer holes anymore, and the retina is flat vision 20/40 or 2 months following surgery. This is a very interesting case, a keratoprosthesis, a child with a vitreous hemorrhage tractional detachment, using the Ingenuity to help me to look at the peripheral retina because the keratoprosthesis is very small. I cannot look very far in the periphery, as you can see with the Ingenuity. So the endoscope is quite helpful to be able to see as far as you want. You can see up to behind the iris. So just to make sure that all my periphery is clean and no remaining traction, I use the endoscope in conjunction with the Ingenuity. So 3D with 2D technology in the same time. Another video. Yeah, this is the chorioretinal coloboma detachment using the bevel tip 10K cutter, 25 gauge. This is a coloboma with retinal detachment. So this is the 10K cutter. As you can see, the coloboma and the detachment here. Doing vitrectomy as a first step of doing this sometimes can be very challenging and very complex detachment with a high failure rate. The reason why high failure rate, because we don't see the breaks. So an idea came to me what to do is to inject membrane blue or membrane dual at the coloboma and shake the eyes, and by allowing this, some of the subretinal the dye will go in the subretinal space, and then you remove this dye and switch to air, there will be a reverse migration. So whatever will move to the subretinal space will go through the holes, and you can identify the holes. So basically, now I'm identifying the holes because the stain went into the subretinal space and detachment. Now it's in the reverse direction. So I can see the breaks identified very clearly. Now I know where to treat, okay? So this is basically a small trick to show you how to identify the breaks and make sure all the subretinal dye should go away. So as you can see here, the dye, I'm trying to remove all the dye, not to leave any dye in the subretinal space before doing the laser treatment and silicone oil injection. As you can see here, this is under air, removing all the dye. This is the edge of the coloboma, which we will be treating soon. So no dye, retina flat, the vitreous is on. This is done with 3D technology, as you can see here. Now I'll be doing laser photocoagulation using the vector to articulating laser probe again by Alcon. This is a new release of laser. So this is done very smoothly. And then silicone oil, the patient did very well with no redetachment. I think we have two more. So this is a way of doing drainage. So what I'm doing here, this is detachment. I'm trying to join the 27 gauge with light bulb to drain transclerally. So putting the 27 gauge needle to silicone oil extraction kit and connecting the Z-bend light bulb with the light and 27 gauge, going transcleral with the light, switch off the endoillumination, you can identify choroidal vessels to avoid them. Then once you are in the right place, you push only the needle, not the light, because they are connected with a buccal, piece of buccal. So you push the needle with full visualization. You can see the needle now in the subretinal space with the bevel towards the choroid, not towards the retina. And then you start with the silicone oil extraction, the fluid removal, this vacuum suction. As you can see, the retina is being flattened with full control. You can stop, you can do anything you want. There's no risk of incarceration here or no risk of bleeding. And then you switch to air and you drain. At the very last drop, you slowly pull out your needle. As you can see, the needle was here and the retina is completely flat. There is no single drop of fluid at the end of surgery. That's why I said it's a full control. You don't need to do endo drainage. I don't like endo drainage. I'd rather do this than do endo drainage. Another case, bevel tip, 10K, diabetic, one-eye patient, single-eye patient, traction detachment, using the bevel tip, which obviously it's safer to work on the surface of the retina, trying to segment and delaminate these very thick fibrous membrane, encroaching the macula and causing macular detachment. As you can see, I'm trying to segment very gently. No scissors, no forceps here, only with the cutter, just to be very careful. And now, with high-speed cutters and certainly the bevel tip, we are getting closer to the retina surface as before. So we feel more comfortable getting to the retina surface, being able to delaminate very closely to where we haven't been doing this not long time ago. As you can see here, removing all the remaining membranes gently, trying not to create any damage to the disc or to the surrounding area. And as you can see, the macula is being freed. So trying to cut all the membranes from around. And finally, air fluid exchange and doing laser treatment. So the last bit of membrane, you can see here, this is 10,000 cut vitrectomy, which is very predictable and very controlled instrument that when you try it, you get to like it really. Just one point I forgot to mention, the lens I'm using here is the Oculus lens on the Resight with the Lumera 700 microscope, if anybody wants to use to know which technology. So most of the lenses I'm using, the Oculus, the single-use one with the Resight and Lumera 700 microscope. So this, at the end, all the membranes has been removed, air fluid exchange, and this is pre-op picture, as you can see here, and this is 3 weeks post-op picture. Patient remained good vision and very happy. So basically, I think this is my last case. Again, thank you for inviting me, and thank you very much for being here with me.